Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome back. How are you doing, Jeff?
I am well. How are you? It's been a few weeks since our last podcast. Excited for today?
And we're in Toronto, and all of a sudden it is now somewhat spring, which means we are literally in sniffles and sneezes season. I don't know about you, but I've seen a heck of a lot of allergies come through my office lately.
I agree. I mean, we see it every year at this season. This season seems to be bad, and I don't even know if the pollen counts are higher or not. So today we're going to talk about tackling allergic rhinitis in Canada.
We are understanding that seasonality patterns are really changing. And if you speak to allergists, they're kind of all meshing together. So I don't know if we can use first principles anymore for ragweed season versus trees and grass, but we'll go over that in a second. Regardless, it's here. It's going to be here for the next few months. And we have some updated guidelines for our patients.
You know, we do. And, before we start, because I still use the mnemonic I learned in med school 100 years ago, the TGR, thank God for ragweed. So trees followed by grass, followed by ragweed. So tree season, we are smack in the middle of it now. March to May would peak right now. And then we have grass, and grass is really peaking in June. And then last but not least, good old ragweed, which peaks in early September, like August. So think of the TGR for all our listeners.
I did not learn that. That's a good pearl. I'm not 100 years away from my medical school education.
I
don't
know,
think
you're only
either.
a few years away. It's very different.
More than I'd like to admit. So, let's backtrack. And I think overall, there is an appreciation that we underappreciate the consequences of allergies. I have somehow started to develop, I guess it's tree allergies. And you're not happy. Your eyes are watering all the time. You feel uncomfortable. It interferes with sleep. We have great evidence that it interferes with your ability to be productive at work, scholastic achievement, academic absences. So I have to remind myself when a patient comes in and maybe hasn't actually made the connection about with their symptoms with a possible allergy, if they come in just saying, I feel tired all the time, I'm drained, we have to ask about allergy symptoms.
Yeah, especially in this season. And you know what I mean? Because we've known our patients forever, people often wonder, they say they come in and they're complaining of these symptoms. How do we know it's not a virus? And there are certainly subtle differences. The seasonality history is certainly a big one. And viruses present differently. They're sicker acutely. They tend to have a cough if it's an upper respiratory thing. But sometimes it can be hard because, as you mentioned, symptoms of allergic rhinoconjunctivitis can be sneezing, congestion, itchy eyes, itchy throat, itchy nose. So there's a lot of overlap for sure. But I think taking a proper history, looking at the patient in front of you, we can probably discern the difference between the two.
Yeah, I think one key sign is if you are doing your, nasopharyngeal exam, there's cobblestoning of the uvula, and that is sort of a pathognomonic sign that somewhat differentiates, people come in with sore throats. You're right. I just think the history is so key. Timing. We were talking just moments before we started recording about the pandemic pet and all the families that very graciously took in stray cats and dogs, and all of a sudden their kids are quote unquote sick all the time. What are we going to do with those? In the history as well, you have to ask them what they're taking, because like many other chronic conditions, patients are accessing things without us necessarily knowing. There is easy access to over-the-counter antihistamines. Can we take a moment to talk about Benadryl?
Yeah, I think we should. We talk about Benadryl and a lot of things, including urticaria, sleep. It is a drug that should not be used.
Zero.
We've been talking about this forever as physicians. Many physician groups have been to Health Canada. It is not a safe drug. It causes sedation. It causes cognitive impairment. It increases the risk of falls. It is a drug that has no place anywhere. I mean, and it's weird for us to say that because we use it in Emerge, we use it for a lot of things. It actually has no clinical place anywhere.
And in most guidelines that you look at, even internationally, the problem is that, it's available in IV formulation. So I think the extrapolation is people go into Emerge, get an IV dosage, and they know they got Benadryl, and they could go to the pharmacy and get Benadryl. So huge teaching point. Are they going to Costco to buy their Benadryl in buckets?
Probably.
Yeah. And so we need to ask, and I think you so astutely say the history is so, so important. We'll talk about treatment of allergic rhinitis, but is it associated with red flag symptoms? So are people having angioedema? Are the allergies getting worse? Are there constant shortness of breath symptoms that would warrant a referral? I mean, these aren't necessarily just treat with over-the-counter suggestions by a phone consult. We really need a patient in and we need to examine them.
I mean, especially in the kids, when you talk about shortness of breath, we often see a comorbidity of allergic rhinitis and asthma.
Correct.
So definitely keep that in mind. But when we're looking at the symptoms, and we do have new Canadian guidelines for the treatment of allergic rhinoconjunctivitis, look at the patient in front of you, look at their symptoms. And if you look at the guidelines, because we talk often about orals versus intranasals, and the guidelines say, first line, if it's mild, you can use oral antihistamines. If you're going to do that, it should be the second generations. I mean, for me now, I tend to use Belastine or Blexten or Rupatadine, Rupall. They're non-sedating. They're very effective. Yes, they're prescription, but in fact, the cost of both of those is similar to buying over-the-counter meds. The other first-line option is intranasal steroids. So if the symptoms are mild or mild to moderate or moderate, intranasal steroid is a first-line option.
Absolutely.
And the one thing we got to remember, and it's something I only learned in the last few years, sneezing is different than significant congestion. The oral antihistamines will help with sneezing. They don't help significantly with congestion. So keep that in mind.
And I mean, I think going back to even basics, saline rinses that everybody hates, those actually have immense evidence. Just remind them to first rinse out their sinuses and then use their nasal spray.
Right. That would help a lot.
But we now have, nasal sprays that are combinations with antihistamines that have been game changers.
They've been huge game changers. And I mean, if you look, so the guidelines say if they don't respond to the first line options, you can use the combinations of the intranasal steroids and the nasal antihistamines. But actually, I got to be honest, if their symptoms are moderate, severe, or they have concomitant allergic conjunctivitis, I'm jumping to the combos because the
100%.
biggest thing is they don't need eye drops. So they're using one spray and they don't need eye drops. There's two combinations on the market now of those. I mean, we have the original one, which is Dymista. We have the new kid on the block, which is Rialtris. Just really, really effective. And patients like them.
Yeah. And I mean, if you speak to the ENTs, there's some patients that are scheduled for polypectomies. And after a course of these dual antihistamine and nasal corticosteroids, they don't need surgery anymore. It's really a game changer. And I think we say allergies, whatever, it really affects the patient's life. People are miserable. They look miserable, right, with their red eyes. But it is, quite frankly, an important diagnosis to make and not so difficult to treat with the options that we have now. When you speak to allergists, allergy testing does have its place. Certainly that pandemic puppy, that's wonderful, but wreaking havoc. I don't have many patients, but I have certainly patients with their children, and they're doing, the weekly injections in my office and are really responsible.
I mean, that's patient preference.
Yeah.
I mean, I feel, as you mentioned, we're so good now with our drugs. But if the patient says, you know what, I don't want to take drugs every year. I don't want to put stuff in my nose. I don't want to take a pill. We now have injectable, like classic immunotherapy. We have oral immunotherapy. And if they want to go, I mean, we talked about it before we went on air today. And most of our patients we self-treat, and it's the minority that I would refer in this regard. But I think there are instances, certainly this has nothing to do with those anaphylactic patients like the bee and the wasp ones where I'll refer for sure. Or the patient just says, like I said, I don't want to take sprays or pills. Let's see what we can do.
Absolutely. We have so many newer options within the second generation antihistamine. So we're writing those prescriptions. We're also counseling, don't take Benadryl, don't take those over the counter decongestants that can actually cause rebound symptoms. And just educating patients that their symptoms aren't mild, they aren't trivial, they cause problems, and we can treat them.
No, so a few other points. I mean, if they're not going to use the combination drug and you're just going to use an intranasal steroid, you often have to add eye drops. So keep that in mind for sure. The other thing that the guidelines often say now, there's evidence that intranasal steroid plus oral antihistamine is not as effective as the
Yes.
combined. So if you're having a yearning that it's so severe that you need to combine oral and intranasal steroid, use one of the combined drugs because they are more effective. So certainly do that.
Absolutely. And I think that once you counsel patients, they kind of get used to it and they work quickly. So there's immediate feedback, which is nice.
The one thing we can mention we talked about originally is the pandemic puppies, as you mentioned. And we see patients like that. It's funny because I'm seeing more of the young people that have a new partner and then their new partner has a cat and they're deathly allergic to the cats. In those circumstances, they can use intranasals. They're going to have to use them most days. The other option they can do is they can use an oral, especially if it's someone they just started dating. They're seeing them once or twice a week. I tell them to dose orally on the morning before they see that person.
Absolutely, 100%.
And it seems to work in that regard also.
Yeah, just setting expectations as well. It's funny, my sister got a pandemic puppy and I am definitely allergic to dogs. It's just not talked about in my house. So I do exactly that, just medicate myself beforehand.
The other things to keep in mind in children also, we should look at the ages depending on the drugs you're using. But we can use intranasal steroids in children. We can use the oral, like the second generations in children, certainly. Depending on which product you use, look at the age restrictions. And once again, we talked about this before, look at that asthma overlap. Don't forget about the asthma overlap in
Yeah,
kids.
and there is some option in liquid forms as well for
Right,
for
absolutely.
kids that can't actually take a pill.
Okay, I think we've covered it all.
We have, and just in time for the promise of spring, although it could snow tomorrow, but at least if
Yeah.
we have that tree eruption continue, we're all prepared.
All right. It's great to see you. Thanks, everybody.
Speak soon.
Have a good one. Bye-bye.